Why don't we get started this afternoon? Welcome. My name is Jim Greenblatt, founder of Psychiatry Redefined, where we've tried for many years trying to educate clinicians on integrative and functional medicine for mental health and mental wellness. I'm going to take a few minutes before I introduce our speaker to tell you all the exciting things going on for April. This is a lecture I'll be giving, I guess, tomorrow night, a free webinar on nutritional lithium and elevated copper and a host of other underlying contributing factors to irritability and aggression in kids. And this is a course I set up for my psychiatric and medical colleagues who we found out quickly knew nothing about nutrition. So it's a basic overview of nutritional psychiatry for professionals with CME credits and a discussion. That also is in April. And then this is our first year, we're going to have a pediatric fellowship, a 1-year program devoted to an integrative and functional psychiatry approach in treating kids. I'll be working with Dr. Nancy O'Hara, who'll be guiding some of the pediatric and PANDAS lectures and other guest faculty, including Claire. And then here's our general fellowship. We've been doing 6 years now in functional psychiatry. So please book a call, join us, ask questions. We're here to help. And but let's get to the punchline. I want to introduce Claire Sennison, who tonight is doing a lecture on the history of autism. She's been a faculty member at Psychiatry Redefined now for over a year. She's an educator, researcher in functional medicine and nutritional therapy. This is an intensive that she'll be doing in the end of May. And so there'll be more information about this later. But Claire has just been a unique addition to our faculty. She brings to her work a passion of lived experiencing of being neurodivergent and diagnosed with autism and ADHD. She's navigated her own recovery from chronic fatigue, dealing with many complex health issues. She has over a decade of clinical experience working with complex illness, trauma, fibromyalgia, and nutritional deficiencies. In the UK, Claire is the head of research at Optimal Health Clinic, and she trains practitioners on protocols to support complex patients. Again, as faculty, she's brought a tremendous clarity to helping our clinicians understand how to work with neurodivergent patients and understand integrative and functional medicine. So, with no way of ending the long introduction, please welcome Claire, and I will stop sharing and looking forward to hearing this presentation with everyone else.
Thanks, Jim. I'm just going to try and share my slides. So hopefully you can see that. And I'll get cracking. So hi, everyone. Oh, failure to move my first slide. Today actually is Autism or World Autism Acceptance Day, which is actually a coincidence that we booked the webinar on this day. But I think even more important to get this message across, because this month is going to be really draining and triggering for a lot of autistic people who are still struggling with their health in spite of all the advocacy we do. So I've been doing these talks for several years now since my late diagnosis, and whilst it has been nice to see increased accommodations and information available, healthcare is actually one area where not much has changed at all. And this is based on what I hear in the autistic community, from my patients' testimonies and my own experiences. So today we're going to talk about why this might be. So these are all reasons why autistic people were denied referral for diagnosis or access to support by healthcare providers. And reading through these, we can probably agree that these comments are grounded in misinformation, in stereotypes, and in deficit-based thinking. But when I talk to healthcare professionals and, kind of ask them, what do you know? What do you actually know about autistic people? A lot of them just start listing DSM criteria, which are a set of stereotypical and external behaviors, usually by autistic people who are in distress. But we know there's so much more to autism than what is described in the DSM. So we're going to look at the history of autism today, and how this medical model was constructed. And then we're going to look at what else autism is, in order to fully understand why this is linked to so many complex health issues. Okay, so this medical understanding came from a stereotype that started in the early 1900s, where the word autism was actually first used by a Swiss psychiatrist called Eugene Bleuler. And he was actually describing schizophrenic patients who were especially withdrawn and self-absorbed, and he used electroconvulsive therapy in attempts to treat them. Then in 1943, an American psychologist, Leo Kanner, published a paper describing 11 children who lacked social instinct, who were focused or even obsessed with objects, and had this obsessive insistence on sameness. And he called this condition early infantile autism. And 80 years later, not much has really changed in the medical autism narrative. But a few years before this, Kanner had hired a German diagnostician named George Frankel, who had also been working in Hans Asperger's lab. So Hans Asperger was an Austrian pediatrician, and he was thought to be the first person to describe autism clinically. And his work describes boys with high intelligence and problems with social interactions, but they could talk endlessly about their special interests. And he called them little professors. He believed these children to be worth educating as they could be productive to society. But others that were deemed less worthwhile led to dozens of children being referred to Nazi eugenics programs to be euthanized. In the 50s, Bruno Bettelheim, who was thought to be a psychologist, but it later turned out he had fraudulent records. He had written articles and made TV appearances promoting his opinion that autistic children experience conditions at home that were similar to Nazi concentration camps, and that autism was a trauma response to this maternal lack of warmth. And he coined the term refrigerator mothers, which many people might have heard of. But Leo Kanner also endorsed this idea that autism was caused by parental coldness. And he was quoted to say, parents just happen to defrost long enough to produce a child. And both he and Bettelheim advised that children should be institutionalized for their own good, meaning they would be removed from their homes. Now, in the 60s, the US Autism Society was founded, and it eventually became a multi-billion-dollar industry with the aim of curing this condition. In addition to antipsychotics, these sedate the children, behavioral treatments also became the mainstream or only option. So Ivor Lovaas, who was a UCLA researcher, the same guy who developed this appalling gay conversion therapy technique, developed a similar therapy program called ABA, Applied Behavioral Analysis, which consisted at the time of aversive punishments like administration of electric shocks to eliminate autistic behavior, and using food and affection to reward neuronormative behavior. And in the 1980s, autism enters the DSM-3, and it's characterized by a lack of social interest, severe communication impairments, and bizarre responses to the environment. And at the same time, studies on autistic girls starts to emerge. Psychologist Lorna Wing heads a lot of this research, and it starts to reveal a difference in how girls display their autistic traits that might be different to boys. So in the 90s, Lorna Wing founds the National Autistic Society in the UK with Judith Gould, and they defined this triad of impairments in language, in social interaction, and in stereotypical behavior. And this sets a DSM criteria. And they also conceptualize autism as a spectrum rather than a linear scale, because of this huge variety in presentations and this multi-dimensional aspects, no two autistic people being the same. In 1944, Asperger's syndrome emerges as a differential diagnosis for children and adults without speech delay, or intellectual impairments, and who have more social seeking behavior. But this unintentionally demarcates Asperger's syndrome from autism, and then becomes associated with these high and low functioning labels. Now, in 2013, with the publication of the most recent DSM edition, Asperger's syndrome is rightly collapsed back into the autism spectrum diagnoses. And for the first time, sensory issues are now formally recognized as a core feature. And it's also finally possible to have a dual diagnosis of ADHD and autism, where one previously ruled out the other. And figures now suggest, anywhere from a 50 to 80% overlap. And we also see added to the DSM related conditions like ARFID and PMDD. So where are we now? Well, as you've seen, historically, autistic people have faced a lot of harm from the experts. 80% of autistic people have difficulties accessing care, and there are significant barriers to all types of healthcare, from primary care to nutrition to functional medicine. And members of the community say that they feel a lack of safety and a lack of trust, and they feel misunderstood, and they often feel invalidated because the DSM criteria, it reduces us to our deficits, what some of us look and behave like when we're in distress, by experts who are often not autistic. And there's little to no nuance of what's actually going on the inside. And this narrative is very much reflected in clinical training and in the scientific literature. So professionals don't feel good about this either. Almost 80% rated their ability to care for autistic patients as poor to fair, and many feel overwhelmed. So, because when you're trained on what something looks like from the outside, that's all you see. You see broken neurotypicals, and the majority of research funding has gone into preventing or fixing autistic people, not authentic autistic well-being. So when we talk about the neurodiversity, which will be in your face the whole of April, being Autism Awareness Month, we're referring to the diverse ways that brains learn and think and experience the world and communicate. And what the neurodiversity paradigm stands for is that there isn't just one correct type of brain. So when we talk about neurodivergence, we're referring to the 1 in 5 people whose brains do things in a different way to what society has deemed normative and largely caters to. So what else is autism? Well, thanks to autistic-led and community-based research, we actually know a lot more about the autistic neurotype that better explains what's going on the inside. So I'm going to go through a few of these with you now. So we have differences in synaptic pruning. So what this means is the connections between neurons that pruned away in non-autistic brains don't get pruned away in autistic brains. This leads to a hyper-connected brain. And what this means for our lived experiences is that everything is connected. And a lot of us are excellent at seeing patterns in large sets of data. We tend to be system thinkers, and many of us find safety in patterns and predictable systems, and we can become really dysregulated when these systems are disrupted. We can also have a thought at bedtime, and it can rapidly cascade into hundreds of interconnected thoughts, like your whole brain lighting up, and that makes winding down to sleep really hard. We also have intense world theory, so which is exactly what it sounds like. But research from over 10 years ago now found that autistic brains generate 42% more information at rest. So imagine how much energy and resources that is going to be using up. But we also have altered sensory gating. So this is a neurological process that enables the brain to filter out unimportant sensory input so that we can pay attention to the task at hand. So if you're listening to this talk, your brain's likely filtering out noises in the background, like sensations of clothes on your body, room temperature, all of that. Well, autistic people are unable to filter out around 90% of sensory input from the environment. So we notice things that other people don't. I can hear people now 2 gardens down from me. And we also experience things more intensely. We have bigger feelings, bigger emotions, and we even have increased neuroplasticity. But if you're generating this amount of information, you're going to need more time and energy to process and integrate all this information. And if that exceeds your capacity, it's going to result in overload and shutdowns, meltdowns, mental fatigue and exhaustion. So this excessive information coming in that we don't have the bandwidth to process is what we refer to as intense world theory. And we might not just be able to quieten down our thoughts because mindfulness, because it literally defies how our brains work. And some of us can get more hypervigilant with these generic, relaxation techniques. Okay, so the double empathy problem was coined by Dr. Damien Milton, who was also an autistic researcher, and his work challenged earlier models of autism, which led to harmful misunderstandings about autistic people having no theory of mind, no empathy. But he explains that the communication differences actually go both ways. Like the communication between 2 people from different cultures, they might struggle to understand one another because of differences in perception and comprehension and language. And his message was that it's that the onus shouldn't just be down to the autistic person to learn and to behave and communicate more neurotypically in order to be understood. And this is one of the key failures in medicine and healthcare. It just isn't inclusive of people with different communication styles. So autistic communication can be very different to what society caters to. So we don't really enjoy small talk or ambiguity. We like to collect details and facts and info dump at great lengths. We tend to be quite literal and direct. We mean what we say and forget that other people don't do this. So we can be very naive and vulnerable to abusive relationships. We can be very repetitive because, for one, it uses less energy than having to, navigate new things all the time. So the double empathy problem, especially in healthcare, is something that we'll talk about a bit later on. Okay, so monotropism and inertia. So this was defined by Dinah Murray, who is an autistic researcher, and it refers to this funneling of attention into one thing, because less things captivate our interests, but when they do really intensely, and these are called our special interests. But when we're in this state of hyperfocus, it can be really hard to pull us out of it, and it can be actually a great way of tuning out the chaos around you by focusing on that one thing. But we can forget to eat. We can miss internal or external cues of discomfort, and then our energy levels or health can become very dysregulated. And we also tend towards inertia, which means that we find it difficult to transition to a new task. So things like even getting out of bed and getting up and going in the morning, it's a huge mental and physical transition for anyone anyway, which is why we have such a huge cortisol spike to get us out of bed in the morning. But we can't always get our bodies and brains going quickly enough to keep up with the pace of society. So the mornings can be really difficult. Researchers have shown differences in presentations between autistic girls and boys, which led to this concept of internal and external phenotypes. So it's thought that the male autistic stereotype was based on external behaviors, whereas girls tended towards internalizing their traits, either because of conscious or unconscious attempts at hiding their traits, masking, camouflaging, or that their traits are missed because of the gendered expectations that we project onto children. So things like, little girls being shy or seen and not heard, or being labeled dramatic if they're having a meltdown. And there are a lot of racial and cultural stereotypes that might mean some of our traits might be missed. I actually read an article that the highest incidence of increase of autism and ADHD diagnoses are in Asian women. However, when clinicians think of autism, they often think of a picture like a little white boy. So finally, we'll go through a few of the neurobiological differences, but there are many. 87% of us have motor, planning, coordination, and sequencing challenges, and this isn't even listed in the DSM. But motor function impacts how, everything, how we move our bodies, how we sequence our thoughts, our ideas, how we communicate, and also how we chew, swallow, move food through our digestive systems. And these are all programs that are run by the nervous system and very key to nutrition and healthcare, but no one's really trained in this. And also a huge part of what autism is our differences in executive function, interoception, and sensory processing. So executive functioning, which you might have heard of, it's an umbrella term that refers to these skills and mental abilities that allow us to plan and organize our thoughts, behaviors, and actions. And we have great difficulty with many of these functions. And they're associated with differences in the development of our different areas of the brain, like the frontal lobe, cerebellum, the insular cortex. Other people can also acquire executive functioning difficulties and, interoception problems through chronic illnesses like ME, CFS, long COVID, burnout, depression, PTSD, and also women going through perimenopause also experience executive functioning difficulties. But then if you're neurodivergent and also going through one of these things at the same time, your brain fog can really amplify. So this is one of the more disabling things in society, because what seems simple to an able-bodied person might not be simple to an autistic person. And a lot of health and well-being advice is very ableist, and it leads to huge health inequalities. So a large proportion of us have interoception and sensory processing differences. So just to briefly go through what that is, interoception is our eighth sense. It allows us to feel our feelings and interact with our external environment. And we have these receptors throughout our bodies, in all of our organs that are constantly pulling information about what's going on and sending this through the vagus nerve and the spinal cord to your brain. And then this information has to be processed in many different areas, but especially an area called the insular cortex. And the insular, it uses these incoming messages as clues to what your body needs in that moment. So it could be a physical thing. Are you hungry? Do you need the toilet? Are you sitting in a comfortable position right now? Are you cold or running low on oxygen? Or it could be affective, so an emotion. So do you feel safe? Are you afraid, angry, bored? And this message has to be contextualized and assigned a meaning by our brain so that it can promote some sort of reflexive urge or behavior or action to self-regulate and bring ourselves back into balance. This is called homeostasis. But self-regulation is actually one of the executive functions that we have difficulties with. So this whole thing can be really difficult. And emotions are part of this sensory processing system. And autistic people have high rates of emotional processing difficulties. You might have heard of a condition called alexithymia, which is related to interoceptive function. And additionally, our stomach receptors could be experiencing sensations. And for some people that they might be able to accurately label that as, feeling nervous or butterflies or being hungry or indigestion. But if you have poor interoceptive function, you may not be able to identify or verbalize what you're feeling with a high degree of accuracy. And this growing body of research suggests that interoceptive challenges underlie a whole range of mental and physical health problems. People with muted interoception can find it harder to self-regulate and attend to their basic physical needs because they don't register discomfort until it's too late. You can miss earlier signs and symptoms of illness and then seek medical help at much later stages of illness or even medical emergencies. Or we might be experiencing things in ways that don't fit the healthcare, the doctor's expectations of typical symptoms, because they're mainly trained on neurotypical experiences. So, for example, like a lot of nutritionists I work with focus on gut signs for things like hunger or satiety, but a lot of people with interoceptive differences feel hunger outside of the gut. So it could be like the throat or the chest or mood changes. Also, people with heightened interoception, which is sometimes called heightened sensory reactivity, they can have negative reactions to seemingly like innocuous stimuli. For one, because we notice things other people don't, but we can also have higher visceral sensitivities, that's organ sensitivity, or the receptors inside of our organs being more sensitive to changes. And sometimes people aren't believed when they describe things like, I can feel where the food is in my gut the whole time, which makes them not want to eat anything. Or I can feel my gallbladder contracting or my body vibrating. They're often dismissed because people don't really know what to do with that information. But we know that, there's quite a few studies supporting the fact that sensory anxiety and trauma is a distinct type of anxiety in neurodivergent people. Okay, so on to the health disparities. Large-scale population studies have found autistic people are dying much earlier than the general population. So our lifespan is shortened by 16 years, and even more if the person has co-occurring learning disabilities. But we're not dying of autism. The leading causes of death are epilepsy, heart disease, and suicide. So we complete suicide at a rate that is 4 to 9 times higher than non-autistic people. And this is particularly high in people with low support needs, aka high functioning autism. Which is why that label isn't helpful, because what high functioning means is that our struggles aren't visible. We don't look disabled enough for support. And this is also true for autistic children, who are 28 times more likely to consider or complete suicide. And interestingly, a survey by Autistic Doctors International found that those who considered autism as a disorder were more likely to attempt suicide. So seeing yourself as a problem or burden that can't be fixed, or feeling like, everyone else can do simple things, there must be something wrong with you. And that all fuels it. Okay, so in 2015, Lisa Crone and her colleagues compared healthcare records of 1,507 autistic people, adults, compared to 15,070 non-autistic matched controls. And the results were shocking, but incontrovertible. Autistic people have higher incidences of health problems across every body system studied. And we can't be sure whether these differences are because of access to healthcare, or providers not taking health complaints seriously, or higher stress levels, or diet and lifestyle. But the data does suggest that autistic people are much more likely to be ill than non-autistic. And health challenges can exacerbate the cognitive and behavioral problems. It's a vicious cycle. Other studies find that autistic women and girls have more physical health challenges compared to autistic males and non-autistic females. So that indicates that autistic females respond to stress in a different way to males. And it's worth pointing out that a lot of what we understand about stress biology is based on males. So even Hans Selye, who's the godfather of modern stress theory, used male rodents. So this fight or flight syndrome is really a male response to stress. Females tend to display a tend and befriend response, so we're less likely to punch someone in the face, and more likely to have a socially motivated behavioral response, often helping other people. But part of the problem is this separation of body and mind. So this fragmentation of medicine into different systems and specialisms. And this can sometimes lead to over-medication or even over-supplementation, like a pill for every ill, without any real attempt to connect the dots. So if you're someone with perceptual differences who doesn't experience digestive sensations or gut issues in your tummy, which is where you're expected to feel digestive things, early signs and symptoms can get missed. And then we tend to present with illnesses when they're in the much later stages. And also some conditions that disproportionately affect neurodivergent people, like endometriosis, already have this painstakingly lengthy diagnostic journey. I think the typical journey takes over 8 years for diagnosis, which is a long time to be suffering. But this can be further prolonged in neurodivergent women. So with this double empathy problem we touched on earlier, we may not be able to verbalize our inner experiences using the right terminology, or perform, the right facial expressions in the way that doctors understand. So our discomfort might be, greatly underestimated and not treated appropriately. And we have this tendency towards chronic and complex interconnected health issues. So Dr. Mel Hauser, who set up All Brains Belong, which is a community for neurodivergent people facing chronic complex illnesses, they describe this as all the things, which is a web of interconnected health conditions. But when we get sick, it can seem like everything, like a domino effect, everything starts to go wrong at the same time. And I always describe this to my patients using the hanging mobile analogy. If you push or pull or put stress on any part of the mobile, everything then just goes off kilter and out of balance too. And that's what it can feel like with our health. Okay, so systems medicine, functional medicine, holistic whole body approaches work much better with complexity like this, but they can still be biased towards neuronormative presentations of illness. So we urgently need to reform here to be more inclusive. Okay, so if the research behind this sort of thing is of interest, I co-wrote an article with Dr. Megan Neff of Neurodivergent Insights, and we did a whole deep dive. It's like an encyclopedic thing entry into all of these systems and possible mechanisms. So you can click on that when you get the slides later. But what I also observed in my clinic is that many late identified adults only realize their neurodivergence after being chronically ill, and then not being able to recover in this expected way, or getting autistic burnout and losing the ability to mask their difficulties. So, or being, so severely broken that they finally met the threshold for these external symptoms. Okay, and just to mention, there's a huge co-occurrence with PTSD or complex trauma. Francesca Harpe and her colleagues found this link and suggested it might be related to how we process information differently. They found that over 40% of their participants showed probable PTSD within the last month, and over 60% reporting probable PTSD in their lifetime. But importantly, what was highlighted was that life events that autistic people described as traumatic are often not recognized as traumatic in the DSM. Things like making eye contact, navigating changes, coping with daily sensory experiences. These experiences can be downplayed or invalidated, meaning that the person doesn't receive any support and feels even more disconnected with themselves. So diagnostic overshadowing is a huge problem. And what this is where signs of autism are dismissed and put down to pre-existing diagnosis like chronic fatigue or perimenopause. Or someone might also be suffering from anxiety and are autistic, and then they're told, it's because you're autistic and that's why you're anxious, and then this isn't supported. So in order to receive appropriate treatment support, we need accurate diagnoses. Otherwise, it can lead to interventions that are not helpful or may even be harmful. So autistic traits frequently get mistaken for personality disorders, such as borderline personality disorder in women or oppositional defiance disorder in Black autistic children, which speaks a lot to how the DSM pathologizes stress behaviors of BIPOC folk or women, even if you're presenting with the same traits. So this Venn diagram here looks at the overlap of eating disorders and autistic traits, where one can be mistaken for the other. And when I talk to nutrition professionals about this, they aren't always aware that, sometimes we use food as sensory input, oral stimming, to regulate ourselves, which might get pathologized and mistaken for binge eating disorder. Or we tend to be quite literal or black and white with health guidance, which means we're more vulnerable to orthorexia. Or we might like diet rules because they give us structure and predictability. And this may or may not be eating disorder behavior, but the reasons behind this are rarely explored. And a range of interoception difficulties can lead to, restricted diets, particularly during times of change or transition. So this is actually the number one thing practitioners bring to supervision. They're often wanting to tease apart these complex, what are complex health issue symptoms and neurodivergent traits, like is IBS actually heightened interoception or sensory, chemical reactivity? Is it a poor detox thing, or is it a sensory processing difficulty? So it is complicated. It's not straightforward. Okay, so this wouldn't be a talk about autism if I didn't talk about masking or camouflaging. But masking is a conscious or unconscious effort to cover up your way of being in the world, to either survive, coexist, or accommodate other people. And this has been demonstrated to increase rates of anxiety, burnout, and suicidality. So it's important to remember that masking is often not a choice. It's a survival strategy. So when people share their diagnosis, it doesn't suddenly then mean they feel safe to unmask. It might be that the mask allows them to hold down a job or gives them social acceptance or stop them being arrested by the police or, so the person may not be willing or able to drop this coping strategy. But if you're a practitioner, some subtle signs you might pick up in clinic are listed here on the right. I'll shout out a few, but fawning is a really big one. So these are trauma responses. And it happens a lot in a clinical setting because of the power dynamic between the practitioner and the patient. The practitioner being this gatekeeper of tests, of knowledge, of medication, supplements, all of those things. And a lot of people have medical trauma from previous experiences of being misunderstood by healthcare providers. Another one is memorizing scripts and rehearsing answers. I used to do this all the time, and it's particularly answers that questions that we don't really know how to answer, like how do you feel? So I used to spend the whole night before a consultation, or maybe 2 days, typing up a whole report and scripting answers to all these therapy questions because I just wouldn't be able to do it in the moment. But that can annoy practitioners. I know it really annoyed a few practitioners, even though I thought I was being helpful. And also we have things like internalized ableism. So this is really prevalent in late diagnosed people. It's related to shame, and it's really rife in the nutrition and wellbeing industry because it's all the shoulds that we tell ourselves we need to be doing in order to get well. Like I should be able to cook everything from scratch and avoid processed foods, should be able to meditate. A lot of these things are not accessible to all of us, or maybe they weren't designed for our types of brains in the first place. But this infographic illustrates why masking is so utterly exhausting and dysregulating, and why it might lead to suicidality when you completely lose your sense of self. And masking is not a conscious decision. Many of us only realize we're doing it when our mental health really starts to decline. So, sorry, this is a really busy slide. But autism itself is not a psychiatric condition, but there are exceptionally high rates of co-occurring mental health conditions, especially the depression and anxiety-related conditions. But additionally, there's a high overlap of multiple neurodivergences. So I already mentioned the ADHD overlap, but also nearly 28% of OCD patients also meet the criteria for a diagnosis of autism. And up to 35% of girls with anorexia nervosa also fit the criteria for an autism diagnosis. One study showed nearly 55% of children diagnosed with ARFID are autistic, but this doesn't actually account for all the undiagnosed children and adults with ARFID and sensory eating difficulties because it's thought of as a pediatric condition when it's not. And it's such a new entry to the DSM, so we barely understand it. So what else have we got? So when it comes to self-harm, up to 65% of autistic adult self-harm and 15% of younger people. So when you see autistic or neurodivergent people in clinic, we can have a lot of sensitivities and atypical reactions to things, especially medications. One study found that 78% of autistic people had unpleasant responses to SSRIs. You also might see, things like where we have the opposite reaction to things like caffeine giving us energy, or supplements, having the opposing effect. It can feel like we're wired backwards. And because of the multiplicity of neurodivergence, rarely travels alone. ADHDers who are also autistic, when taking stimulants, they can have increased sensory difficulties or worsened interoceptive function. So in addition, behavioral interventions, including ABA, where the goal of the therapy is to make the person appear more neurotypical in order to get by in society. Autistic people have said these interventions tend to encourage masking, and we know the correlation between masking and mental health now. So it's not surprising that rates of PTSD and suicidality have increased. So as practitioners, especially functional ones who think outside of the box, we have to consider brains that learn and think and experience the world in a different way to what is dominant in society. So one divisive thing is screens. So I'm not sure what all of your thoughts on screens are. Yeah, are they good, bad? There's certainly a lot of studies saying they're associated with high rates of anxiety and depression, especially in younger generations. But this study, published recently, found that autistic people actually use screens in a different way to non-autistic people, which I've broken down in this infographic. But in autistic people, screen use wasn't related to anxiety or depression, where non-autistic people said they found online interactions less meaningful than in person. Autistic people said online interactions actually removed some of the barriers to connection, like having to make eye contact or having to process several lines of communication, at the same time. So it's clear that what works for one neurotype might not work for another, and we just need to take time to understand, how someone's brain's working when they're regulating themselves in their preferred way before we make these recommendations based on how the dominant brain in society works. Okay, so like every practitioner here, I like to practice in an evidence-informed way, but there are a number of shortcomings of evidence-based medicine on many marginalized populations. And this is one of the reasons that the community feels this lack of safety and trust in experts. But research tends to focus on fixing. It sees autistic people as broken neurotypicals, and the language really reflects that. So very little research is actually focused on what it looks like for an autistic person to be well. When we use lab ranges, and I would say this is worse for functional lab ranges, but you have to bear in mind that these normal values will be based on healthy populations. And don't forget that the medical model sees autism as a disorder. So when you're looking at your gut microbiome panels or neurotransmitter panels or whatever, you just need to consider that there are no normal autistic ranges. So you're aiming for neurotypical ranges. And I'm not saying not to use labs, because I use them a lot. I love them, but we just have to question things and know this so we can contextualize the results. Also, autistic rodent models, which is what the majority of medication and supplement research is based on. Well, they create autistic mice by either cutting out part of their brain, the corpus callosum, or they injure it with using sodium valproate, a chemical. And then these mice exhibit behaviors that scientists have labeled autistic. So I'm not even going to comment on that, but it's low-key insulting. As with everything in medicine, the evidence base just lacks diversity. What autism looks like in different cultures and different ethnic groups. So we just have to be mindful of this when we're using these tools. So the impact on clinical practice is here, as listed on the right. And it means that we're using tools that aren't very effective, accurate, or specialized. And a lot of our evidence-based approaches are very ableist and discriminatory towards disability or those with executive functioning difficulties. So, what does it mean to be neurodivergent affirming as a healthcare provider? Well, it's a very hot topic. Neurodiversity is a very hot topic at the moment. And I've seen a lot of people claiming to be experts and neurodivergent affirming and using all the fashionable terminology without really doing the work of, unlearning, relearning, or listening to lived experiences of people who are neurodivergent and facing chronic illness. But really, at the heart of it, we center the person as the expert of their bodies, and we believe and we validate their experiences so they feel safe in our care. As clinicians, we might have to challenge prior beliefs and question whether the evidence fairly represents the person we have sat in front of us. And when we see more of these clients, we then gain the clinical experience in complexity. So often I hear practitioners say, "Oh, I've never seen anyone react to, B vitamin or probiotic, or have sensory gut issues. So I just know they've not got that experience with this type of client. And I wouldn't endorse them." But we also have to be bridging the communication gaps and being aware of the double empathy problem in medicine, so you can make healthcare more accessible, and that the onus isn't just down to the autistic person to be working really hard to be understood. And most importantly, we need to be studying the outliers. So these are people who are excluded from studies because they have too many conditions, or they're too severely ill to participate, or they might have an adverse reaction to something and drop out the study. But these are the canaries in the coal mine, that are the most complex patients that turn up in our functional medicine practices. So in medicine, when we do our training, there's a saying that if you hear hoofbeats, think of horses, not zebras. So what it's warning doctors to do is to think of the most likely thing it could be, and not to chase, the less likely explanations. But when you're working with neurodivergent people with complex health issues, you have to think of zebras. What else could this be? So final slide. This is something I share with people because I know there might be some clients, patients on this webinar. So I share this with people looking for an affirming provider, or if you're a practitioner yourself, maybe reflecting on how you might answer the questions. But what do you know about autistic people? So if you're still awake after this webinar, you probably know a little bit more about how our brains work. Asking them, do you personally know anyone who is autistic? Or how many severe or complexly ill people have you seen in practice? Or do you have personal experience with, XYZ condition? So you really want to understand if the person has experience of the canaries in the coal mine or lived experience, because really the personal or lived experience is about humanizing the condition or the humanity behind the label. Because so many of my friends didn't understand CFSME until they got long COVID, and they finally knew what brain fog meant or executive functioning problems meant. And you can always ask, can you explain your rationale to why you came to that decision? Because it should be a thought out process. So people will be happy to share that with you. Okay, so I think I did put one extra slide, which I don't know how I'm doing for time. I want to leave a bit of time for questions, but this is just a little guideline to balancing evidence-based practice with neurodivergent needs. And it's not always easy, but we have to balance our diet and lifestyle interventions with someone who has low spoons, low capacity, invisible disabilities, easily overwhelmed, or executive functioning problems. And we have to balance, using symptom criteria or standard assessments with people who have maybe perceptual differences and communication differences, so or interoceptive differences. And especially nutritional therapy, if you're prescribing a lot of restrictive diets and protocols, like there's some really restrictive diets, or you're asking someone to go gluten-free or dairy-free, we have to bear in mind that a lot of us have sensory issues with food, and that's reflected in our eating patterns and behaviors. So we need to prioritize safety, sensory and psychological safety first. Okay, so when you get these slides, I've put loads of resources, further information, if I used any terminology that you didn't quite catch, there's a glossary at the end and loads of references. Okay, I'll stop the share so I can, I think we've got time.
Yeah, absolutely. Now, thank you, Claire. Incredible presentation. I want to make sure everyone knows that we'll be sending out the presentation to listen to, and the slides were so rich as resources that people wanted to make sure that they would be getting copies. So we'll be sending those out. And do you want to look through some of the questions?
Oh, yeah, sorry, I'm just pulling that up. Sorry, my computer's frozen.
Or I can ask one
Oh,
while you're
yeah,
looking.
yeah, that would be.
At what point do you think the diagnosis is overused? Do we over stigmatize?
So, what? So, could you repeat that? I'm not sure I understand.
Yeah, it just do you think the diagnosis has been overused and over stigmatized?
Overused and over stigmatized. I think it's really hard to get a diagnosis. I just know so many, especially, I mean, I know so many different people going through the process, children and adults, late diagnosed, like late identified adults. And I know it's, the waiting lists are horrendous. People rarely go to get a diagnosis if they're just happy and they want to abuse. I don't know if this is the nature of this question, but if they just want to receive accommodations, they often go because they're at their wits' end. So I don't think I would have gone to pursue a diagnosis if I hadn't been suicidal and my mental health had completely tanked. So I don't think it's overdiagnosed. I think it's underdiagnosed. I think just the understanding of autism has evolved, and it's more, it's reflecting neurodiversity. It's more common than we realize, but society hasn't really catered to different types of brains thriving. So that's what we really need to be looking at. So I'm not sure if I understood the question or answered it.
Yeah, no,
That's
I think that was it. How about, have you used plasmalogens in your patients? I'm not sure what that is.
Acknowledgements. If I can see it, um,
It's in the Q&A.
yeah, I think my thing's really crashing a bit. I mean, I can answer that. No, I haven't, because I wouldn't
Okay.
be trying to find the spelling if I had. I haven't, no.
Okay. How
But
about,
I do work with, I mean, in the advanced practice workshop that we're doing, a lot of what I'm doing is tying together things like neuroinflammation and stress, and kind of it sort of explains why we're more prone to things like long COVID, because of this kind of immune dysfunction. So if that is the behind the question that they're asking, yeah, there is a link with immune dysfunction, autoimmunity, neuroinflammation, and all of those are linked to things like dysautonomia. So yeah, I believe that's probably why they asked that question. I haven't used that in particular, but we do use other kind of ways of supporting that.
and Claire, how about, have you found a relationship between post-brain injury and autism?
Yeah, I mean, like, it's one of the, I know both ADHD and autism, it's something like in the 90s, it's genetic, it's hereditary, but then there is a percentage of people who don't have that in their history. So traumatic brain injury is one way of having an acquired neurodivergence. A lot of clients, especially the ones that weren't picked up in childhood, who don't seem to have that the early developmental history, we do look for things like brain injury, PTSD, and it's really confusing for them to kind of tease apart what might be a neurodevelopmental change. But having a brain injury, a traumatic brain injury, or even PTSD does change the way your brain develops and your sensitivity to stress. That you then it does create a type of neurodivergence.
Right. Are you aware of the telepathy tapes in Kai Dickens' podcast?
Yes, I won't comment on it because, yeah, I'm not going to comment on.
Okay.
It's a really interesting. Um, it's a it's a nice podcast to listen to. I'm not sure I agree with everything in it. That's what everyone's gonna go listen to it now. Make your minds up yourself. But it's yeah, it's I don't believe every autistic person is telepathic. But I do know that we have different ways of communication. And yeah, that's kind of all I'll say on it.
Okay. How about if a person is diagnosed later in life with like chronic fatigue or multiple environmental illness, are there certain childhood traits um, that might have predisposed, I think is the
Let
question.
me try and find the question.
At 1:35 p.m. What sort of childhood traits they may have experienced?
If a person's diagnosed later in life due to what sort of childhood traits may they have experienced and how they're able to adapt earlier? Oh, okay, I see. I think they're asking if that person has gone under the radar and they have had another illness like chronic fatigue, CFSME, yeah, what might they have experienced? So it is linked to high ACEs, both autism. We've seen, the research on autism and PTSD, from a very young age. If your brain is developing atypically, it's going to increase stress. So we see biomarkers like low natural killer cells, which is the type of white blood cell that helps you fight infection. That is found in autistic children and it's strongly linked to stress. So stress suppresses this type of white blood cell. In conditions like CFSME, one of the underlying things, and long COVID, one of the underlying things is immune dysfunction and low natural killer cells. So there's a parallel with that. So that's an interesting sort of thing. So one of the things is, well, stress. If we reduce if childhood traumas and stress and the person was supported earlier, that may not suppress their immune function or cause immune dysfunction. That would lead to something like a chronic complex illness like CFSME. That even if you do present later in life with this type of immune dysfunction, you can work with it, which is what we do with chronic fatigue. But when we work with chronic fatigue, it's never just, oh, the virus did it. You soon find there's a whole trail of immune dysfunction that started very early on. So that's kind of what we unpack in functional medicine. But yeah, we kind of look for these links.
Let's take one more question and then we'll need to stop. Are there genetic SNPs that might help identify where the problem might be, or do you use that in your clinical practice?
What I use, it's more the nutrigenomics because the genome-wide association studies, they don't really show anything that interesting. There are some, I know in different conditions like ADHD, autism, there are differences in things like the serotonin receptor SNP, the dopamine receptor SNP, and that can predispose you to certain traits, certain sensitivities, like PMDD is a really big one. But not everyone who's autistic has that, so it's then not necessarily helpful. We tend to use nutrigenomics, so the things like methylation, SNPs, GSTM1, so this is a sulfur type detox gene, and that's often either deficient or underactive. And that can lead to it can exacerbate the anxieties or mental health issues or chronic health issues that some of us have. So identifying that can be really helpful because you can help personalize the treatment. Unfortunately, what some people do is then give you a ton of it, so your brain's never done it, and then you suddenly get a whole bucket load of that supplement, and then we tend to have sensitivity reactions to that. So I think that's where the understanding how to work with neurodivergence is a little bit more, we take a gentler approach. So yeah, I don't know if I answered that question.
Great. No. So I just want to thank Claire for this incredibly insightful presentation and just the compassion and the advocacy and helping healthcare professionals do a better job. I learned so much today, as I do every presentation that I hear from Claire, and I know the comments in the chat have been incredible. So Claire will be joining us for a more intensive program in May. And, as we discussed, we have lots of free content throughout April and May, helping clinicians understand how to think a little more carefully about mental health and mental illness. So thanks for joining us, and thanks, Claire, for this incredible, insightful, personal presentation. Take care.
Thank you very much. Thanks, everyone. Bye.